I'd like to thank everyone for joining us on today's webinar on contracted behavior services. Couple housekeeping reminders before I turn it over to Melantha. Um, Make sure your lines are muted, please. We mute your lines upon entry. However, every once in a while, gremlins get in there, and there does end up being some feedback that goes on. So we appreciate you being able to mute your lines as well. Um, if you have questions regarding today's content that's being presented, we ask that you put those questions in the Q&A box. If you have technical questions, some concerns about, if there's sound difficulty or how things are operating, please put those questions in the chat box. And with that, I am going to turn this over to Melantha, let her tell you a little bit more about her, and get started with today's webinar.
Good afternoon, everyone. This is Melantha Witherspoon, and I am the Eastern Area Behavior Analyst. I am here today to talk about contracted behavior services, so thank you guys for taking a break during your day-to-day and joining me. I would love for everyone to walk away from this webinar with the understanding of what to expect from quality behavioral services, when it's the appropriate time to request those services, and to gain a good understanding of the service coordinator's role. So let me give you a little input about what the service is. It's a therapy-based service from the principles of science that demonstrates why a particular behavior or behaviors are occurring by defining the behavior and examining what is going on in the environment and developing strategies to address those undesirable behaviors that are happening through teaching a new skill or shaping a skill that a person is not completely using thoroughly while decreasing undesirable behaviors. This service is designed to help people who are displaying challenging behaviors, and that kind of looks like a person that has difficulties with communicating their wants and needs. They may hurt themselves or others. They access the community hospital. So this service is designed to address those significant deficit areas in hopes of preventing out-of-home placement and hospitalizations. So who needs these services? As I stated earlier, people who struggle to communicate their wants and needs. If a person struggles to understand what a healthy relationship is, they really can't read social cues. If they're displaying unsafe behaviors, such as when they get upset, they run out of the home and run into traffic. If they display self-injurious behavior, if they are displaying behaviors that lead to them smearing bodily fluids. If people are on 3 or more psychotropic medication, that's an indication that they could be struggling. If they have limited access to the community, their personal belongings, specific areas in their homes, they need behavioral services. If a person requires a PRN to help them calm down, if people are placing them in restraints or holds, that's an indication that another level of support is needed. If someone has a higher level of staffing, if they're in ISL services, a behavior analyst could support that team in reducing the need for 1-to-1 or 2-to-1. And these are just broad categories. If you are a service coordinator and you go into a home where the parents have an 18-year-old child and they don't have a social life because they are fearful about leaving their loved ones with someone, then that's an indication that they may need to figure out why the child is displaying unsafe behavior. Also, if that 18-year-old is going to school and the school is implementing a behavior support plan and they use a safe room at school, in most situations like that, they'll need behavioral services in the home environment as well. If you are a service coordinator and you do some monitoring in one of your ISLs and the staff report that they're fearful to interact with the person or they struggle to tell the person no because it will lead to unpredictable or unsafe behavior, that person is another person that would benefit from contracted behavior services. So this process starts with a functional behavior assessment. And this assessment explains why the behavior is occurring. And once the service is put in place and the licensed contracted behavior provider starts developing a functional behavior assessment, it involves the behavior analyst in, interviewing people who know the person who is displaying unsafe behavior. So they may meet with the guardians. They may meet with a person who works extremely well with the person. They may meet with the person who struggles to keep the person safe. They're going to go in many different environments. So if the person is at day program, the behavior analyst is going to do some observation at day program. They'll do some observation in the home. They'll also go into environments in which the person is not having lots of problems. They may request that the team or the family collect data so that they know which behaviors are occurring and how often and what time of day. It will involve caregivers completing a checklist. They may review historical information such as social service reports or discharge summaries from hospitals or medical reports from physicians. So all of this information will guide the development of the behavior support plan. It's also important to note that a functional behavior assessment is only current for 2 years and is necessary. It's required for the development of a behavior support plan. So I'm going to give you some additional information about the functional behavior assessment and the role of the behavioral provider as well as the service coordinator. The contracted behavior provider is responsible for reviewing those results with the team. So once that functional behavior assessment is completed, it is a great time for the entire team to come together. So that's the service coordinator, that is the home manager if the person's an ISL, the person that is the focus of the functional behavior assessment, home manager, direct care staff, service coordinator, everyone to come together, and the licensed contracted behavioral provider will review the results of the assessment and give them a guideline for next steps. After the FBA is completed and the units are, so typically it takes about 30 to 45 days to complete the functional behavior assessment. Also, every functional behavior assessment may not warrant the need for behavioral services. So a functional behavior assessment may be completed and the assessment may reveal that the team may need to focus on quality of life things or address medical issues. So the assessment may reveal that other services are needed. So after the functional behavior assessment is done, a behavior support plan is written, and a behavior support plan um, will include a summary of the function for each undesirable behavior. So it'll list the unsafe behaviors that the team is hoping to see a reduction in, while identifying skills that a person needs to develop in order to replace those unsafe behaviors. The behavior support plan is a part of the person's ISP, um, and it is composed of analytic procedures um, developed to systematically address behaviors to be reduced. And only licensed, contracted behavior providers are responsible in the DD world for writing those behavior support plans with support from the team members. So what's included in the behavior support plan is like I said earlier, a summary of the function for each behavior. So it should say Johnny displays elopement in order to escape from unwanted demands such as dishes or interaction with unpreferred staff. It should include the graphs, and the graph should include a display of the behaviors that we are looking to reduce, as well as behaviors that we hope to see an increase in. It should also include any changes that occur in the person's life. So if the person changes homes or a new service such as counseling is integrated in the person's program outside of behavioral services, those things can be noted on the graph as well. The behavior support plan should have behavioral goals. So we should know that there is a plan to reduce physical aggression while the person works on their negotiation skills. There should be a list of proactive, positive strategies. These are things that the team will do in order to prevent the behaviors from occurring, and we hope to see lots of those things included in the behavior support plan, as well as what the person will be learning. Data collection procedures will be outlined in the plan. There should be a data collection sheet. The plan should also tell how team members will be trained, and guess what? All team members have the opportunity to be trained on a person's plan, and I encourage team members to service coordinators, parents, guardians, home managers, administrators. If you have a very challenging person, sit through the training with the behavior analyst or contracted behavior provider because that is available to team members. So the behavior support plan should also include the steps to take when someone is displaying unsafe behaviors. So it should be a recipe, step by step, what needs to occur when self-injurious behavior is happening. If there is physical restraint or timeout procedures, and there should be a specific criteria identified when to implement those procedures, and how the person will be monitored for medical issues. Also, it's important to note that if a person has a safe room or their timeout procedures are being implemented, those procedures require special approval from Dr. Terry Rogers and the Regional Behavior Support Review Committee. You just cannot implement those procedures without required approval. The plan should also include justification for restrictive interventions. So it should identify the least restrictive interventions that were attempted and explain what make those procedures not as effective and why the more restrictive procedures are necessary. And there should be competency-based training, and that's spelled out as to how that's going to be implemented and overseen. So I got a question, and someone asked in regards to the including of behaviors related to why meds are prescribed, would this be information included from the physician? So I am strongly, the division is strongly encouraging behavior analysts to work with the community psychiatrist. So that information is guided by the psychiatrist and outlined in the behavior support plan. So behavior analysts can attend psychiatry appointments with team members to gather this information. So if you're going to see Dr. Walker, the psychiatrist, and he's prescribing Abilify, we want to know what behavior is related to the Abilify. And so Dr. Walker may say, I am prescribing Abilify to reduce Johnny's aggression. So you would just create a medication list and a list of Abilify, reason for use to address aggression. And so it's not the behavior analyst explaining why the Abilify is being used. It is the psychiatrist, and hopefully it leads to, the goal is for it to lead to the behavior analyst then taking the behavioral data to the psychiatrist and sharing that there have been 0 occurrences of aggression, or we see a peak in aggression, and we've looked at environmental things. The environment is enriched, and there are lots of positive interactions with the staff and Johnny. So please share some insight with the team. I hope that answers your question. If not, please feel free to ask additional questions. So the role of the service coordinator is to facilitate team meetings to discuss the need for behavioral services, to share a list of the contracted behavioral providers with the guardian, to provide the guardian with a list of questions that may be helpful when the guardian is attempting to choose the best provider for their child. So it may not be beneficial for a person who has high behavioral needs. And an example of that is if the person is um, injuring multiple people, requiring law enforcement um, involvement. They're in and out of the hospital. Um, it may not be beneficial for that guardian to select a person that is newly licensed and most of their experience is working with children who on language acquisition. So having a list of questions to see if the provider has experience with working with someone who displays very unsafe behavior at high rates that lead to injury. So just sharing questions that, again, support the family in choosing the most appropriate provider based on their loved one's needs. They're also responsible for completing the addendum and making sure the addendum is turned in to UR. They're responsible for entering the units into CMOR, as well as removing them when there is a change of provider or there is if a person transfers to another region, just making sure those units are no longer in CMOR and assigned to the right person. And also setting up that meeting when that FBA is completed, assisting the contracted behavior provider with setting that meeting up, and if at the functional behavior assessment meeting, the entire team decides that they want to be trained, kind of facilitating that meeting as well. I have another question. Is there a list of questions? Yes, there is. This presentation will be emailed out with additional documents. So, yes, you will get a copy of those questions. Additional responsibilities for the service coordinator is monthly. They should be receiving progress notes from the contracted behavior provider that, has graphs on there. And hopefully on those graphs, in most cases, we should see an increase in skills being learned, as well as a decrease in those undesirable behaviors. So service coordinators should review those monthly progress notes. That'll also give them an indication of how that person is doing. And if the person is not stable, that's a good time for that service coordinator to bring the team together to have a problem-solving meeting and request additional support from the area behavior analyst, which there are 3 of us. Lucas Evans is the central area behavior analyst, and Rita Cooper is the western area behavior analyst. And you can request support from the area behavior analyst or the regional behavior support review committee, which consists of contracted behavior analysts who would love to support teams and stabilizing people who are struggling by reviewing behavior support plans and ISPs. So I have another question. Is the service coordinator responsible for notifying the provider once units have been approved and entered into CMOR? That is a good question. I am going to have to get further information about that because it currently is my understanding that most agencies have a billing person identified and there's a notification once units are in CMOR, but I will make sure that I answer that question once information is sent out with questions and answers, just to make sure that I have the correct information. So how do you request the services? So it's very, very simple. The team just needs to identify a need for the service. So they're going to come together. Um, I, the area behavior analyst created I think it's a two-pager that is simply a checkbox sheet. It lists behaviors that are happening, that could possibly be happening, and it also identifies medical things as well as different environments that the behaviors could possibly occurring in. So if the team comes together and completes that sheet, and an addendum is completed, which is step 2, requesting a need for the service. The service coordinator will share a list of contracted providers with the guardian. The guardian then makes a selection. Sometimes this involves a person getting the services immediately, and sometimes it involves a person being placed on a few wait lists. So once the provider is chosen, the information is then sent to UR. UR reviews the information and approves the services, and then the information is entered into Seymour, and the behavioral service provider is then a part of the ISP team while units are authorized. So once the units are in Seymour, things that the team should be experiencing is, like I said earlier, the licensed contracted behavior provider is responsible for completing that monthly progress note. And that monthly progress note is very important because it lets the team know how the person is doing. So any team member should be able to access that monthly progress note. So that is something that you should expect. If the person is a person with high behavioral needs, a person that prior to or the initial part of behavioral getting behavioral services in place, if they were accessing the hospital, if they the team was calling law enforcement, if there are lots of restraints to get the best outcome, the team should meet monthly or quarterly to kind of monitor that person's progress so that barriers can be addressed immediately versus waiting and people are experiencing despair. So the licensed contracted behavior provider may identify a barrier, may also have lots of solutions to address those barriers. So it is good for the team to come together and meet to assess those barriers as well as success. While receiving behavioral services, we should be seeing behavior support plan addendums. So as the person is making progress, there should be modifications to the plan as well as if the person is not making progress. That means we need to look at strategies, or again, you have the option to consult with the area behavior analyst or a committee of contracted behavior providers. There should be ongoing training. So the licensed behavior analyst should go in and train on the behavior support plan. They should go in and ensure that the folks that were trained understand what has been trained and is implementing the plan as written. There should be a procedure in place if people are struggling to implement the plan, so that someone may require more training or um, additional aids while they're training. So lots of training should be occurring while um, someone is receiving contracted behavioral services. And then just to reiterate things that I said earlier, expectations for our contracted behavior providers is we expect our contracted behavior providers to meet with the team to review the findings of the FBA. FBA should not be emailed to service coordinators. The team needs to come together and understand why these behaviors are occurring and understand the next course of treatment. The contracted behavior provider is also responsible for sharing the number of units that they'll need to provide services so that that information can be entered into CMOR. The contracted behavior provider is responsible for developing the behavior support plan and making sure that team members are trained with competency. They're responsible for completing the monthly progress notes, which should include the goals, graphs, and any barriers to progress, as well as things that are working well. They're responsible for changes with the behavior support plan. So they are the folks that are going to write the behavior support plan addendum that is support of the person's ISP, and the behavior support contracted behavior provider is also has the option to seek support from the Regional Behavior Support Review Committee. So what should happen when people are not making the type of progress the team will hope? Again, it's a great time for the team to come together and do some problem solving. So a team meeting should occur. And at that team meeting, there should be data. IONs can be, individual observation notes can be brought to the meeting. MARs that include medical diagnosis and the list of medications. If there are any other services in place, progress notes for those services. So the team coming together and identifying what the problem is, who the problem belongs to, reviewing what's tried, what was not successful and why those things were not successful, and coming up with new strategies. So if things are not progressing, then having a team meeting. I had a question. Is the focus person, is the consumer responsible? I'm sorry, is the consumer expected to be at that meeting? I am going to say yes. In most cases, that person can give you a lot of insight as to what is not working for them. They may be able to share what it is that they need, and you can really develop some goals around that person's wants and desires. We've, at least in the St. Louis region, we've had several meetings with people who have high behavioral needs. They've attended Regional Behavior Support Review Committee, and no restraints were required. Police were not called. They came there and they shared their experience, their day-to-day experience, and it was very insightful. So, Randolph, your question is, are providers trained on the requirements of the documentation? Who provides the training? Can you give me a little bit more information about the question? I don't want to make any assumptions. So when you say trained on the requirements of their documentation, I would like to know a little bit more about that. I have another question. Is it expected that the BCBA meet and review the completed BSP with the support team prior to implementing any training with staff? So I think that it doesn't have to be two separate meetings. I think once the behavior support plan is developed, the team can come together and we can the purpose of the behavior support plan can be discussed as part of the training process. But a great time to set expectations for the behavior support plan is when the BCBA is reviewing the findings from the functional behavior assessment. So that's a good time for the contracted behavior provider to say that it is my expectation that I have at least 60% of the day shift and evening shift at the changes shift on the 5th and the 10th to do training. And then the provider can say, we have the capacity to do that, or we don't have the capacity to do that. So a good time to set expectations for the behavior support plan is when you review the functional behavior assessment. So hopefully, thank you, Becky, for responding to my question. So hopefully this webinar includes providers on there. So this is a notice for everyone of what the monthly summaries should include. Contracted behavior providers know that they should have visual analysis of data. They know that goals should be listed as well as how the person is doing to meet those goals and barriers. So this is the time that I'm sharing with the world that is what is required for that monthly progress note. And I am pausing because I'm getting lots of questions. I'm trying to read the questions and answer them. So thank you guys for being patient. So I am under the understanding that progress notes in the world of applied behavior analysis and monthly summaries are the same thing, and so those things should be emailed to the service coordinator because it's a part of the person's ISP. So I have a question that I am going to have to get additional information about. The question was, um, if a person is receiving behavioral services and they are um, receiving additional services from the same provider, another service, um, should that information, should the progress note from both services be placed on the same note? I want to say no, but I am going to consult with people who make those decisions, and I will have an answer for that. And um, the question and answer response. Colleen, if you send me your email address, I will share the unit for behavior services information with you as soon as I get back to the office today. So we have established that if a person is not doing well, it's a good time for the teams to come together, the team members to come together and review the monthly progress notes, data, medical issues, and any other supports that are in place, and do some problem solving. So you can take that first option as well as take the option of getting some additional support from the Regional Behavior Support Review Committee. That first team meeting, it should have the outcomes of new strategies, new action items for team members. But again, you can have that meeting and you can get additional support from the Regional Behavior Support Review Committee. And this is information about the Regional Behavior Support Review Committee. Currently there are three committees. We are working on a fourth committee. The Eastern Committee, I chair it. The Central Committee is chaired by Lucas Evans, and Rita chairs the Western Committee. We meet once a month for approximately 4.5 hours. Meetings are typically 30 to 45 minutes. Folks do not have to attend in person. You have the option of attending in person or joining by phone. The committee is optional. However, if a person has prohibited procedures, an example of prohibited procedures are if a person is living in a Medicaid waivered funding environment, ISL, or home, and locks are being used to keep the person from eloping, then that is a prohibited procedure, and Regional Behavior Support Review Committee would not be optional in that case. I discussed earlier if timeout procedures are being implemented, that is another situation in which Regional Behavior Support Review Committee is not optional. If there are any forms of mechanical restraints, teams should definitely come together and come to Regional Behavior Support Review Committee. There has been a lot of success with reducing prohibited procedures. Okay, and I just want to make sure that I'm clarifying. I appreciate all of these questions that will help everyone understand things. So the monthly progress note or the monthly summary, I am using those things, those words interchangeably. Um, they include the graph and the goals and how the person is doing to meet those goals. So, yes, please send that visual analysis, how the person is doing with meeting the goals, all of that on a document to the service coordinator. So the service coordinator can know how well that person is doing. To give you some additional information about members of the committee for the Regional Behavior Support Review Committee, they are contracted behavior providers who have experience in applied behavior analysis. And so again, you can self-refer to Regional Behavior Support Review Committee. The behavior analyst can say, can the committee take a look at my behavior support plan and give me some feedback? A guardian or service coordinator can say, hey, my team is struggling. Is there any way possible we can meet with a Regional Behavior Support Review Committee, and you guys will be able to access that support. And if you live in the central region and the dates for the central region don't work well for you, you can meet with the committee in the western region or in the eastern region or vice versa. Just a few more things that I think are important about ABA services. A behavior support plan is not valid if there is not a contracted behavior provider providing oversight, which means the contracted behavior provider has the units in Seymour. They've written and developed that plan, and they are monitoring the implementers of that plan to ensure that they have a good understanding of that plan and are implementing the plan as it is written. It's also important for teams to understand that the contracted behavior provider can be a great support. They should be included in hospital discharge meetings. We talked earlier about how they can attend the psychiatry appointment, so data can be collected on those symptoms of behaviors associated with psychotropic medication to give the psychiatrist a visual analysis of, is the medication doing what it is prescribed to do. They can be a part of the debriefing process agencies have when incidents occur, or if a person is not able to access certain parts of the community or things in the home, bringing them in to get feedback about all of those things. So just including the contracted behavior provider in those meetings can be very helpful to the entire team. Everyone providing support to the focus person can be trained on the behavior support plan. You can even include the CIT officers or local law enforcement officers prior to the person moving to a certain area or when the person is struggling, so that there is not treatment interference. So making sure, everyone that's a part of that person's life is trained It's also important to know that there is a mechanism in place for a person to receive counseling and behavioral services, and the behavior analyst and the counselor should be sharing their courses of treatment. I got a question. Is there a mechanism in place for billing for when the behavior analyst is attending those hospital discharge meetings or psychiatry appointments? Yes, there is. You can use the family treatment guidance code. You just need very good justification explaining that this person is struggling behaviorally. You're trying to minimize the use of the hospital, just clearly documenting things so that if Medicaid comes, you have good justification for it. So yes, there is a mechanism for contracted providers to bill for those meetings. Unfortunately, I got a question in regards to becoming a contracted behavior provider. The process right now takes a nice amount of time, and when I've asked provider relations, is there a way to expedite that? Currently, there is not a way to expedite becoming a contracted provider. They have to make sure those background screenings are done and providers have their policies in place. So, unfortunately, there is not a way to speed that process up. So I got another great question. Who will obtain permission from the psychiatrist to participate in the psychiatry appointment? So the guardian can obtain any necessary consents that need to be obtained. Psychiatry is a service that the person is paying for, and so it is my hope that there's not barriers with obtaining consent. But again, that's an example of expectations that can be discussed and reviewed once the team meets with once a team meets to review the functional behavior assessment. That's a great question. I also wanted to make sure everybody is aware that service coordinators are not responsible for entering or authorizing any units for state plan services. But it is helpful for service coordinators to understand that there is, MoHealthNet has a website that lists all of the approved behavior analysts that can provide ABA services. So that's on mohealthnet.com. It's very simple. You simply select the county that the person lives in. You select the service, which is ABA services, and it will give you a list of all the approved providers. It's also important for service coordinators to know that most of our state plan services have short-term behavioral health case management, and you just simply call the number on the back of the card. Some of the like United Healthcare may have a nurse's line where the nurse navigates that behavioral health case management, and then home health may have another step in which there's a risk assessment done, but it's good to know that there is short-term behavioral health case management to help families who need more support with navigating state plan services. And it's also good for the service coordinator to work collaboratively with the home health case manager. There are two committees that teams can access support from, and that's ECHO and the Regional Behavior Support Review Committee. So if you have a family that's in a natural home setting, ECHO and the Regional Behavior Support Review Committee would love to review documents and offer recommendations that lead to improvement of that person's quality of life. So that is the presentation. If you guys have questions, I have time, so please ask as many questions as you like. That's a great question, Celia. Thank you for clarifying. Yes, ECHO serves individuals with autism, and in order for a person to access state plan services, they have to have a diagnosis of autism. So thank you for clarifying it. Yes, the Family Treatment Guidance Code can be used for people who are in residential services for training, for coordination of care with the psychiatrist or any other collaborative team meetings where the contracted behavior provider is trying to get that person stabilized. These are great questions. Okay, so I got a question about how do I locate the list of behavioral providers. So if you are wanting to know about the behavioral providers for people who have a diagnosis of autism that are 21 years of age and under, that information can be found on apps.dss.mo.gov/FMS Medicaid provider search. So that's the way that you access the approved contracted providers for MoHealthNet. If you are wanting to know about behavioral services for people outside of that box, there are multiple ways to access that information. The easiest way is to get the list from the service coordinator assigned to that person, and they can access that information and see more. And if I'm not mistaken, most providers have access to see more, which may allow them to access a list of contracted behavior providers. So I got a great question about only being able to bill an hour a day of training. That definitely is not enough to train on the entire behavior support plan. So it's going to require some pre-planning so that um, you have multiple trainings um, so that people get trained on the entire plan. So you can't bill for um, more than an hour a day of training. So um, again, it's just going to require some um, pre-planning. So maybe the first day of training, you're focusing on the proactive procedures and skill acquisition, and then the next training you're looking at reactive procedures and following up on skill acquisition. So we are definitely aware that you only can do 1 hour training a day. So just have to pre-plan. I'm going to give you guys about 2 more minutes because I don't have any more questions coming in. I would love to get more questions. I definitely understand the struggle with um, training, some of the struggles that come with training. I did not do a good job of talking about that meeting when the team comes together to review the findings of the FBA. So that is a good time, again, for the contracted behavior provider to outline what he or she needs in order to have success. And it's a good time for the provider or the guardian to say, I can do this or I can't do that. So again, when you're meeting with that ISL provider, you're meeting with that family, you've completed the FBA, you know you should have a training system established. So just clearly identifying what your expectations are. I need to have, like I used the example earlier, I need to have at least 60% of your staff here on the 5th and the 10th so that people are trained, and I need someone from the administrative staff to go in and do observations or fidelity checks. So you as the contractor provider, you can outline what you need in order for success to occur. You need a simpler mechanism for the staff to collect data so that you can actually show improvement. So you're outlining exactly what you need. And hopefully, people are able to meet somewhere in the middle. All right. I don't have any more questions coming in. I can respond to any other questions in the follow-up email that will come after this presentation, along with other documents that may be helpful for behavioral providers and service coordinators. Again, thank you guys for your time.